Good afternoon, all. I'm Dr. Suparna Ghosh-Cherath, leading the nutrition program at the George Institute for Global Health. On behalf of my institute and Resolve to Save Lives, I would like to welcome you all to this webinar titled From Consensus to Action, Potassium-enriched low-sodium salt substitutes, consensus statement and its translation into clinical practice and utilization as a public health strategy to address hypertension and cardiovascular diseases in India. I would now request Professor Vivekanand Jha, Executive Director, the George Institute for Global Health, to deliver the welcome address and also introduce the process of development of this consensus statement. Over to you, Professor Jha.
Thank you very much, Dr. Ghosh-Cherath. And it's my pleasure on behalf of the George Institute for Global Health India and the Resolve to Save Lives, the two organizations that have been really partnering for a while to ensure that, yes, this message gets across and is disseminated in as effective a manner as possible, because we think, and I hope all of you on the webinar agree. If some of you have still some lingering doubts, hopefully by the end you will be convinced that this is a very, very effective public health intervention and will potentially lead to saving of several million lives worldwide, including in India. Given that India is the most populous country in the world, and any change in any of the health indicators in India also moves global health indicators because of the sheer size. So our focus in this webinar, there are a number of things that we can do with regard to improving overall population health. But over the next couple of hours, our focus is on this specific intervention, which is the use of low sodium salt substitutes for prevention, control, and management of, here we say hypertension, but I would actually broaden it to major non-communicable conditions, which includes hypertension, cardiovascular disease, mental health, neurological conditions, kidney disease, etc. as well. So that's something which we which some of it has less evidence than the others, and so we'll use just one tracer condition, which is hypertension, and cardiovascular disease is really a catch-all phrase, which also includes conditions like kidney disease, peripheral vascular disease, etc. So can we go to the next slide, please? Thank you. So as Dr. Ghosh-Cherath mentioned, we'll recap the process that we have followed to get to where we are. And we are at the top tier here, which is shown as dissemination. But we started a long time ago. We started with trying to collect all the evidence that we have on the impact of low sodium salt substitute on hypertension, cardiovascular disease. We had 6 research questions that we specifically looked at. After that evidence synthesis was completed, the findings were compiled into a white paper. That white paper was subsequently presented in a consensus conference with experts, and that experts was a multidisciplinary group of experts, not only those people who are already familiar with the topic, but also those who don't usually discuss this, but involvement is really critical to ensure that, yes, this is scaled up, this is widely accepted, etc. After the consensus conference, obviously we had more inputs, and those inputs were integrated, and that led to a generation of the consensus statement. And that consensus statement is available, and the teams, the George Institute teams and the Resolve to Save Life teams will be very happy to share the consensus statement with you. And then it will lead to, it has led to already development of policy brief and the webinar, which is what we are doing today, which is the dissemination activity. Next slide. So what is the consensus? Next. So the consensus conference had a few objectives, right? One of the objectives was actually to review the global evidence and build consensus on the use of low sodium salt substitute. And here I introduced this term potassium-enriched because the low sodium salt substitute also has this additional ingredient, which is very important. It just is not low in salt, but it is also high in potassium, high in the sense of that it contains potassium, right? No, normal salt does not contain potassium. And so we reviewed the evidence on the effectiveness, efficacy, and safety of this particular salt substitute. But then, even if something is effective and is reasonably safe, there is still a major barrier to be crossed, which is implementation of any intervention. As medical practitioners, we are all aware that any new intervention is not automatically implemented, but it requires deliberate steps to do so. And in a complex and diverse country like India, this is all the more challenging. So we explored the potential pathways which could help with the implementation at a ground level. And finally, we realized that successful implementation and scale up requires change in policy and also requires change in the way programs are implemented. So programmatic decision making also needs to be modified. And so we specifically captured expert opinion using a Delphi process to establish what was the level of agreement on the various potential statements that would come out as supporting the use of low sodium salt substitute as a public health intervention. Next slide. So this was the Delphi process, and the participants who were involved included a wide range of medical practitioners, cardiologists, nephrologists, and researchers who don't even do clinical practice, but family care physicians, general physicians. We also had public health experts who understand how population health interventions are implemented, and a very important stakeholder, nutritionists, were also present. And to ensure that we represent the diversity of India, they came from all over India. And they sat together in a room to evaluate the available evidence from both a clinical perspective, but also public health perspective. Next slide. So the Delphi exercise required the participants to indicate their responses on a 9-point Likert scale. And the Likert scale, I'm pretty sure that most of you are familiar with how it works. So on the left-hand side, you can see the zone where participants indicate their disagreement with a proposed statement, and the disagreement, depending on the score 1 to 3, it could be strong disagreement to moderate degree of disagreement. In the middle is people who sit on the fence. They neither agree nor disagree, or have mild degrees of either agreement or disagreement. And towards the right are people who are willing to commit to supporting the statement, either again moderately strongly or very, very strongly. Next slide. And these statements are grouped under 4 domains. The domains related to efficacy, which means impact on blood pressure and cardiovascular disease outcomes, because if that is really the basis of undertaking this whole process. Because if it does not really make any difference on blood pressure and cardiovascular outcomes, then really the rest of the process becomes immaterial. Then following efficacy, we looked at the effectiveness, which means real world applicability and population level impact. And finally, safety, because any intervention needs to be safe as well. In particular, because it contains potassium, one of the risks that has been highlighted repeatedly is the risk of increase in the level of serum potassium, which could be potentially dangerous. And that danger is increased in certain populations, such as those who have kidney disease, and that's the most important one. Then the statements were also directed towards public health and policy. And importantly, how can this be adopted and implemented in terms of its acceptability to communities, its affordability, how is it regulated, and how can this be scaled up? Because all of these are important, because if any of these pillars is missing, then implementation becomes a challenge. And lastly, we also realized as responsible healthcare practitioners as well as researchers that the knowledge generation is a continuous process and it doesn't stop there. But what else can we do to improve the evidence base, not only for this, but also to generate new evidence? Next slide. So the consensus really was that the low sodium salt substitute is a cost-effective, evidence-based intervention that prevents cardiovascular events and premature death. And this took into account that the actual cost of potassium-containing salt is a little higher than the regular salt, but still, if we evaluate it in terms of what it will do by way of saving lives and reducing disability, it turns out to be a cost-effective intervention. And that these consensus statements are endorsed by a wide group of people, which includes experts. And since then, it has been endorsed by medical societies as well, and multiple organizations, including the two organizations that are spearheading this process, as shown there. I think that is the last slide from me. So thank you very much. We'll carry on with the dissemination activity. So I'm going to hand back to Suparna, and I think next is going to be Manika, is it?
Yeah, thank you. Thank you, Professor Jha. I would now like to invite Dr. Saeed Imran Farooq, Executive Director, India Resolve to Save Lives, to kindly give the keynote address. Now that Professor Jha has set the stage about what this consensus statement is about, we need to need to have some views on what is the background under which we started this exercise. So Dr. Saeed Imran Farooq is a seasoned public health leader with over 22 years of experience in designing and implementing impactful health programs across India. And not only India, but Southeast Asia and beyond. And at RTSL, Dr. Imran leads national initiatives on hypertension control, salt reduction, and trans fats elimination while supporting the government of India's Ayushman Bharat mission to strengthen primary healthcare systems. Over to you, Dr. Imran. You're muted, Dr. Imran.
Okay.
Yeah.
Now
Yeah.
am I audible? Thank you. Thanks, Suparna. And thanks, the George Institute, for organizing this and having a RTSL here. So today's webinar, as Dr. Jha has said, that this is an important step in disseminating the consensus statement on the use of potassium-enriched low-sodium salt substitutes as a public health intervention in the country. We are looking at population-level impact of replacing the high-sodium salt with a low-sodium salt, which is a potassium-enriched salt. So this consensus statement, as Dr. Jha said, that it has been developed after multiple rounds with clinicians, nutritionists, and public health experts, and intensive review of evidence and discussions. The objective for today's webinar is we would like to lay out the evidence in front of our audience. We would like to have these expert recommendations disseminated, and we would try to help you understand so that you can advocate for these consensus to be a part of the national policy for preventing NCDs in the country. We all know that NCDs and hypertension is a growing burden for the country, and almost 1/3 of the population of the country is affected by it. There is a direct link between the salt consumption and the sodium content of the salt and hypertension. There are studies which say that almost 175,000 lives are lost to excess salt in the country among the cardiovascular deaths. So we need to decrease the consumption of salt, but also the sodium content of the soil and try to provide population with the protective effect of potassium, as Dr. Jha said. So this we talk about changing the habits, we talk about behavioral change communication and IEC, but these interventions take a lot of effort as well as individual drive and commitment to make it happen. We need something which will change the context, and changing the context is replacing the harmful sodium with a protective potassium. We all know that this type of public health intervention will help Government of India realize its commitment of reducing population level sodium intake by 30% and also lowering the risk of hypertension and other CVDs in the country. I wouldn't talk much about the development of consensus statement as Dr. Jha has already elaborated on that. What we are trying to do is make you believe that this strategy is effective, this strategy is efficacious, this strategy is safe. The low sodium salt is safe. This has a potential of being a public health and a policy reform intervention. And we recommend how to implement and what further research is required in this area. So we will deliberate more on this. What I would like to say at the closing is that this consensus provides us Indians with a practical evidence-based pathway to reduce sodium intake and the risk of hypertension and cardiovascular disease burden at scale. Let's work together to help ourselves and help the countries resolve to save lives. Thank you. Over to you, Suparna.
Thank you, Dr. Imran. So we will now move on to our technical session on the presentation of the consensus statement, which is divided into 4 thematic areas. So Professor Jha will be speaking on the first thematic area, which is the effectiveness, efficacy, and safety of low sodium salt substitutes. This will be followed by 3 more speakers. On theme 2, Dr. Manika Sharma. She is the Principal Advisor, Food Policy at Resolve to Save Life. She will be presenting theme 2. Manika leads RTSL India's initiative on promotion of healthier diets to prevent diet-related non-communicable diseases. And with over 15 years of experience in public health and nutrition, she specializes in advancing evidence-informed health and nutrition policies and scaling data-driven programs across India and South Asia. Our third speaker will be Professor Sailesh Mohan, who is a professor at Public Health Foundation of India, and he is the Deputy Director, Head Cardiovascular Epidemiology, and Secretary Governing Body at the Center for Disease Control. He is involved in chronic non-communicable disease research, teaching, training. He leads several NCD research projects at CCDC. And our final and fourth speaker will be Dr. Meenakshi Sharma, who is a distinguished scientist with over 3 decades of experience in public health research, specializing in cardiovascular diseases, stroke, and neurological disorders. She has served at the National Institute of Communicable Diseases before joining Indian Council of Medical Research. She has led several clinical trials, including the INSTRUCT trial. She will speak on the 4th thematic area, which is research recommendations. So over to Professor Jha for the first thematic area. Over to you, sir.
Thank you, and it's a privilege to be joined by my eminent co-panelists. So I'm back, but this time I'm going to talk to you about the theme 1. As Suparna laid out, and trust me, I'll be back one more time before we call this webinar to a close. So this theme was around the effectiveness, efficacy, and safety of low sodium salt substitute. Next slide. So the statement says that we agree that switching from regular iodized salt to potassium-enriched low sodium salt substitute can significantly lower the risk of heart disease in both the general population and people with high blood pressure. The benefits of low sodium salt substitute are derived from both sodium reduction and potassium supplementation? This is a question that already has come in the chat. So I'd like to emphasize that not only reduction in sodium intake, which is independently required because we consume far more sodium than we should, intake of increased potassium is also independently associated with blood pressure lowering effects and cardiovascular benefits. So not only lowering sodium, but ensuring that it is substituted with potassium is important. Why this is even more important is that in normal Indian diets, our daily potassium intake is far, far lower than what is recommended. Okay, so we are already at increased risk because we take much lower potassium than recommended, in addition to taking higher salt, higher amounts of salt. All right, and indeed, there is now evidence to suggest that most of the benefits come from the potassium supplementation as well. So this is what you see in the graphic below, that there is reduced sodium and there is addition of potassium, and all of those together, they lead to lowering of blood pressure and a risk reduction of cardiovascular disease, kidney disease, etc. And an important point to make, just in case it wasn't clear to people, is that this leads to almost no change in the taste of this low sodium salt, right? So there have been a number of surveys where people have not been able to tell the difference when offered both types of salt without telling them which is which. All right, so that's very important, because if salt does not taste like salt, people won't take it. So it has to taste like salt, even though it contains less sodium. Next slide. It looks like salt, it tastes like salt. And this is this, and just wanted to also add that the statement that you saw on the previous slide, this is now supported by very high quality studies, multiple studies, including a large study which was conducted in China, and we'll come to that in a minute. So on the basis of all of these studies, a number of organizations, which includes the WHO, they are fully convinced that this should be now a general recommendation. And so they have recommended lowering sodium and increasing potassium to prevent morbidity and mortality due to cardiovascular diseases. All right. And once again, at the risk of repeating myself, potassium counteracts the effects of sodium. The greater the potassium consumption, the more we excrete sodium in the urine. And potassium also helps in causing our blood vessels to relax. When our blood vessels tighten up, or in medical terms we call constriction, vasoconstriction, our blood pressure goes up. And when our blood pressure relaxes, then the blood pressure goes down. Okay, so again, you see the same thing on the graphic on the right, increased sodium excretion, reduced blood pressure, cardiovascular disease prevented, and of course, the blood vessel relaxes. Next slide. So the next statement says that we recommend this low sodium salt substitute for all people who have high blood pressure as routine adjunctive intervention. So even as we ask them to take drugs as physicians, or we ask them to improve their lifestyle, stop smoking, etc., we should be recommending the use of low sodium salt substitute at the same time. Right? So this is important because it has additional blood pressure lowering effects, and we may actually thereby reduce the need for reliance on blood pressure lowering medications. However, there is a note of caution that there are certain populations in which the risk of this low sodium potassium containing salt substitute, the risk of development of increased potassium level, as I mentioned earlier, is higher. And these are people who have advanced kidney disease because kidneys are the organs that excrete potassium. If the kidneys are failing, then our body is not able to excrete potassium. And in that situation, we don't want them to be taking even more potassium. Or if because of some reason someone is already taking potassium supplement, then of course they should not be taking this low sodium salt substitute. Then finally, there are certain kinds of diuretics or drugs used to increase the flow of urine. Those also cause retention of potassium in the body. And if someone is taking those, then they should not be taking low sodium salt substitute. All right. So that's the point also shown on the graphic below. Next slide. And look, it is not enough simply to make a prescription, because changing our habits is not it's not trivial, right? So we need to also implement behavior change communication strategies, and they have been advocated alongside the recommendation for replacing salt with the potassium containing salt substitute. And once the combination of behavior change and prescription of low sodium salt substitute will lead to then reduction of sodium, both systolic and diastolic blood pressure. And this is followed by a reduction in the incidence of stroke, right? This is very important. It also leads to a reduction in cardiovascular mortality. And finally, and for many people, it will be very important as well, is that it improves overall quality of life. And this is all demonstrated by studies, and we'll come to that in 1 second. Next slide. The third statement is that in people with kidney disease, so now we come to this special population. And there also, there is no blanket recommendation of not using low sodium salt substitute, because our kidneys are very resilient organs, right? And they have a remarkable propensity or capacity to adapt. So if the kidney disease is in early stages, our kidneys are still able to adapt and excrete potassium enough so that the risk of increased serum potassium level is not there. So early stages of kidney disease, which we call stage 1 to 3, and there is a value given there which medical professionals will understand, indicating the level of filtration function of the kidneys. Of people with lower degrees of kidney disease who do not otherwise have any other problem and are not taking any of the other drugs can easily continue to consume low sodium salt substitute. However, there is often this belief in the minds of many people that certain people, like old people, people who have diabetes, etc., they should not be given this. And that's a myth, because these are very large number of people, and in fact, they stand to benefit the most from routine use of low sodium salt substitute, because they are the ones who are at the highest risk of development of cardiovascular disease and stroke. And the more is the risk, the greater is the benefit of any intervention, including low sodium salt substitute. All right. So these are the common questions that medical practitioners are asked or nutritionists are asked. Can people with kidney disease use low sodium salt substitute? So the answer is there, yes. In early stages, they can. How about, as I said earlier, people who are old, who have diabetes, etc.? Yes, they can also take low sodium salt substitute. Next slide. The next statement is that, and this is again a repetition of a point that I made earlier, is that the benefit comes also from potassium supplementation. And in fact, 3/4 of the blood pressure lowering effect is likely to be because of increased potassium. And in fact, now the more recent kidney disease guidelines also point out that there is no need to strictly restrict potassium in people with kidney disease, and that high dietary potassium may be productive in early kidney disease as well. Next slide. this is the trial I was talking about. This trial is called the SAS trial. This was run by colleagues from the George Institute for Global Health. Professor Bruce Neal from George Institute, Sydney, was the principal investigator. And this was conducted in a big population, more than almost 21,000 adults living in 600 villages in China, 5 provinces of China. And the headline findings of the trial are that they were divided into 2 groups. One group was asked to take low sodium salt substitute, and the other one continued to take regular salt. And in the end of the study, the researchers found that people who consume low sodium salt substitute had a lower risk of development of stroke. And you can see the risk ratio. So 14% reduction, reduction in the major cardiovascular events also, which included heart attack, heart failure, or any disturbance of the rhythm of the heart. Again, reduction by 13%, and 12% reduction in death, which is really important, right? Everyone understands there is nothing after that. So even 12% reduction in death as well. And importantly, there was no significant increase in the in serious adverse events which are attributed to clinical hyperkalemia. So summary of the evidence was that it delivers substantial benefits without producing any undue risk in these individuals who obviously did not have advanced kidney failure. So you can see what was done. As I said, almost 21,000 individuals, and the intervention is there, and the comparison was normal salt, and the primary outcomes are listed there in the box, all of which we have already described. Next slide. I think that's it, and we now move on to the next domain. So back to you, Suparna. I think it's Shailesh.
Thank you, Professor Jha. I would now like to invite Dr. Manika Sharma. Dr. Manika.
Thank you so much, Suparna, and thank you, Dr. Jha. Next slide, please. So in the previous section, we learned about the recommendations from the consensus statement regarding the effectiveness, efficacy, and safety of low sodium salt substitutes. The following set of 4 recommendations deal with public health and policy aspects, and they are meant to suggest policy pathways to ensure that benefits of low sodium salt reach the general population. Next slide, please. The first recommendation is that LSS be integrated into the national NCD prevention strategy. This is supported by the high population burden of hypertension. Next slide, please. Next, thank you. So just coming back to the evidence that on which the statement builds. Basically, India currently has a very high burden of hypertension. The National NCD Monitoring Survey 2017 to 18 indicated that around 28.5% adults aged between 18 to 69 years have hypertension. ICMR's India B study also indicated that about 1/3 of the population has hypertension, with very minimal difference between different regions across rural and urban areas as well. Additionally, we know that Indians consume excess sodium and the intake of potassium remains low. The average daily intake of sodium amongst Indians is almost 2 times the WHO recommended intake of less than 2,000 mg per day, whereas the potassium intake is only about 50% of the WHO recommendations, which is at least 3,500 mg. Additionally, India is also committed to reducing population level sodium intake. Dual benefits of low sodium salt in reducing sodium intake and increasing potassium intake has proven, as we saw in the last presentation, to reduce blood pressure and the risk of associated cardiovascular diseases. Specifically in the Indian context, the salt substitute in India study indicated that replacing regular salt with potassium-enriched low sodium salt substitutes containing 30% potassium chloride had a significant impact in lowering systolic blood pressure. Systolic blood pressure was lowered by around 4.58 mmHg. Given the high burden of hypertension, excessive sodium and low potassium intake, and the effectiveness of low sodium salt in reducing blood pressure and associated cardiovascular diseases, LSS could become an important element of NCD prevention in India and therefore should be integrated as a part of the strategy. Next, please. This is the second recommendation. It states FSSAI should update standards and labeling rules to recognize potassium-enriched iodized low-sodium salt substitutes as an approved edible salt category, requiring a clear label aligned with scientific evidence that provides appropriate caution for those at risk without being overtly restrictive for the general population that stands to benefit from the use of LSS. This recommendation pertains to the regulatory aspects of low-sodium salt. Next slide, please. So what the recommendation entails are basically two things. Number one, categorizing low-sodium salt into the edible salt category, which helps recognize it as a safe and approved food product. And number two, it talks about the labeling. The labeling on low-sodium salt should be transparent, should be based on scientific evidence, and should provide information of both the benefits as well as the risks. For the population that is at risk of developing hyperkalemia, as mentioned by Dr. Jha in his presentation, it should provide appropriate caution. And for the general population, it should not be restrictive so as to dissuade them from using low sodium salt and gaining its benefits. Next, please. The third recommendation under this set of recommendation is basically indicates the setting where LSS should be used as a replacement of regular salt for the highest impact. It states, given that approximately 3/4 of sodium intake in India comes from discretionary salt used in home cooking, we recommend that LSS primarily target household consumption. This differs from high-income countries where processed foods account for most sodium intake. Population-level substitution in homes, community kitchens, and midday meal programs offer the highest potential impact. Next slide, please. So the scientific basis for this recommendation comes from the three key sources of salt or sodium intake. In our diets, we consume sodium through three ways. First is through the salt that's added to food while cooking or eating at home, which is known as discretionary use of salt. Second is sodium that's consumed from the food that's prepared outside of home. This includes foods that are prepared in restaurants, through street vendors, or the ones that are consumed through large-scale procurement programs. And the sodium that's consumed through the consumption of packaged and processed food. Therefore, specifically in the Indian context, as per the consumption pattern, where majority of our sodium intake comes from home-cooked food, it is recommended that the replacement of regular salt with potassium-enriched low-sodium salt should be done at the household level for maximizing the potential benefits for the population. Next slide, please. This is the last amongst the public health and policy recommendation. It deals with iodization of low sodium salt. It states, we recommend that low sodium salt substitutes be iodized at appropriate concentrations to maintain adequate population iodine intake while reducing sodium. The iodization should follow WHO recommendation, that is adjusting iodine fortification levels based on salt intake. For example, if the salt intake is reduced to 5 grams per day from the current levels, iodine should be fortified at approximately 39 mg per kilogram salt. The basis, next slide please, the basis for this is to balance iodine and sodium. This recommendation aims to balance iodine nutrition with sodium reduction. Low sodium salt available in India should be iodized, and the level of iodization should be in line with the WHO recommendations, and also at the same time aligned with the level of sodium intake in India, so that the benefits of both iodization as well as sodium reduction reach the Indian population. Just to give a quick recap, from a public health and policy perspective, the group of experts, after the review of scientific evidence, had 4 key recommendations. This includes that LSS should be integrated into the National NCD Prevention Strategy. Second is updating the standards and labeling rules for low sodium salt. Third is that LSS should primarily be targeted for household consumption for maximizing benefits. And the last is that iodine should be, low sodium salt should be iodized at appropriate concentrations as per the WHO standards. Thank you. I think this was my last slide. Back to you, Suparna.
Thank you, Manika. Now over to Professor Shailesh Mohan. He will be speaking on theme 3, which is recommendations for implementation. Over to you, Professor Mohan.
Thank you, Dr. Suparna. I hope I'm audible. So I'll try to present some of the key recommendations on translating elements of this consensus statement.
Dr. Mohan, sorry to interrupt. Your voice is a little feeble. Yeah.
Is it better?
Little better.
Can I continue, or I can try taking off the headset and reconnecting?
Yeah, I think that will be better because it's a little low.
Just give me a minute. Is it better now?
Yes.
Okay. So I'll try to describe in the next few minutes the implementation efforts that are needed to convert some of these key recommendations into practice. Can I have the next slide? So the first key recommendation in this consensus statement is that, the fact that's accepted by this group is that the implementation remains a key challenge. So for LSSS, low sodium salt substitutes to be adequately incorporated into the strategies, we need national guidelines that include both non-communicable disease prevention guidelines as well as hypertension guidelines to incorporate and recommend the routine use of low sodium salt substitutes in the place of regular salt for the general adult population with well-defined contraindications, which were eloquently described by Professor Jha, so I won't repeat that. In addition, the consensus is also that the FSSAI, which is the leading regulator in India, should update the standards and the labeling rules to recognize potassium-enriched iodized low sodium salt substitute as an approved edible salt category. So essentially, the first recommendation wants to advance policy endorsement, improve the guidelines, and also the standards as far as FSSAI is concerned. Next, please. So when we look at the current multi-sectoral action plan, which has actually ended a couple of years back, it calls for 30% reduction in sodium consumption by 2025. So it also emphasizes some regulatory reforms, and this could be one potential area that could be leveraged for promoting the use of low sodium salt substitutes, in addition to other recommendations that are there in this action plan. In addition, as I indicated in the previous slide, the FSSAI can carry recommendation with appropriate warnings that low sodium salt substitutes are the right way to go for the vast majority of healthy adult population, and with the recommendation or the warning for particular subgroups, as Dr. Jha has mentioned in his presentation. Next, please. The second key recommendation in this consensus statement is that it should be physically and economically accessible. So this is one of the key barriers, because we have evidence that low sodium salt substitutes are, first of all, not readily available all across the country at all levels. And secondly, they are also more expensive, in fact, twice as expensive compared to normal salt. So affordability is clearly a major barrier in addition to availability. So policies need to be targeted to increase the availability as well as make it more affordable, so that a large majority of the population can actually benefit from the health benefits that accrue from consumption of low sodium salt substitutes. And for this, several suggestions are there, including using fiscal methods like changes in the taxation, providing production subsidies, etc., to bridge this gap in price. Next, please. So there are clearly challenges that are always highlighted by the food industry. One is that most of the potassium chloride is imported. There is high cost involved in that. There are costs involved in formulating, reformulating. There are also costs that are involved in actually advertising and marketing this product, because this is often considered to be a very niche product. So what it results in is that the cost is almost double. For instance, a normal kilo of salt will be around 24, 25, and this is about 50 rupees per kilogram. So clearly it limits affordability and restrict access. So we need policies to work around this so that there is better access and seamless availability. Next, please. The third recommendation, which is the cornerstone, in fact, of this whole salt reduction strategy, is the requirement for appropriate behavioral change strategies that can build trust, that can increase demand. So there is potential in social marketing campaigns, but the messaging should be simple, straightforward, evidence-based, and concrete. For instance, a simple message could be that same level of saltiness could be achieved with less amount of sodium, and that can lead to lower blood pressure. So it's a win-win situation for both consumers and those who recommend this. So it should be clearly backed with evidence, which it is, as we have learned from the previous presentations. And there are a wide variety of community-based groups and organizations can be co-opted to enhance and innovate in this area so that we have tailored behavioral change strategies that can promote the use of low sodium salt substitutes. And I'll describe an example from a project in the next slide that we have done with support from RTSL. Next, please. So there have been some evidence from India on using different types of innovations in promoting behavior change for advancing the use of low sodium salt substitutes. The George has supported the implementation with funding from RTSL of leveraging ASHAs for this purpose. We have received support from RTSL to look at how we can improve the utilization and uptake of low sodium salt substitutes. So we did a study in Andhra Pradesh through delivering structured education and education plus subsidy in 2 arms. And we found that education as well as education and subsidy both increased the utilization of low sodium salt, but the impact was more in the education plus subsidy arm. So what we did was we provided subsidies to consumers through wholesale network so that they paid the same amount as they would pay for a kilogram of normal salt. While we did not see change in hard outcomes because the intervention period was pretty short, we did see sustained impact because people at baseline were unaware of the health benefits of using low sodium salt substitutes. Once they were convinced, they were ready to pay the price, even at the end of the study, and 30% of the sample continued to use low sodium salt substitutes. So it indicates that there are ways and means to increase availability. We also work with the retailers and wholesalers to ensure availability. So it shows we can increase availability through a whole of system approach, working with different stakeholders. And once the demand is created, people are actually willing to pay because they see benefit in switching to a different kind of salt. Next, please. So finally, one of the key stakeholders in this whole business are healthcare professionals, and they need to be appropriately educated so that it becomes part of their routine hypertension management and counseling. And they should be encouraged to identify people who will benefit from this and also identify people who needs to be cautioned or in whom use of potassium-enriched salt substitute should be avoided. And this has also been described very well before. Next, please. So finally, ultimately, everything comes down to effective policies and programs. And for that, we need government support. And one way governments can support, and which is a low-hanging fruit, is to support healthy public procurement, particularly in schools, workplaces, and other healthcare institutions, etc., which operate large institutional food outlets or canteens, so that when they procure for their staff or students, they can procure the healthier alternative, which is the low sodium salt substitute instead of usual salt, and replace, in that way, achieve replacement of salt in their foods, as well as in packaged foods and restaurant meals, and promote and advance the use of low sodium salt substitutes. So this requires a whole of system and a whole of society approach, which is quite relevant in the current scenario, given that we are following the multi-sectoral action plan in India. I think that's the end of the presentation. Thank you very much.
Thank you, Professor Mohan. Now over to Dr. Meenakshi Sharma. Dr. Sharma will be speaking on theme 4, which is on research recommendations. Over to you, ma'am.
Can you switch on my presentation? Good afternoon.
Yes, yes. Aishwarya, kindly share screen.
Can you make it full screen, please? Aishwarya? Yeah. Thank you, everyone. I think most of the things have been covered by the previous presenters. We all agree that low sodium salt supplementations, they are going to reduce the cardiovascular disease burden. That's a consensus statement which is coming out. And policy recommendations and public health recommendations have already been mentioned by Dr. Salesh and Dr. Manika. So coming to the research recommendations for LSSS, what I felt was that though we have studies in general population which show the efficacy and safety of these salts, however, there are some high-risk populations which need to be targeted, and we need to study what is the impact in these populations. That was one of the things. So the first recommendation, can you come to that? The first recommendation is to quantify the effectiveness of LSSS in high-risk groups through trials that test effectiveness and safety outcomes. So when we are going to test the safety outcomes, definitely, as we all know, that there are going to be ethical issues, and those ethical issues will have to be taken into account. Next slide. There are, as I mentioned earlier also, there are a number of studies which are coming from India as well as from China and other countries, which indicate the benefits of using potassium-enriched salts in general population. The studies are like, these studies, they show that this reduces the cardiovascular risk by 14 to 18%, which is a huge amount in a country which is the diabetes as well as the heart disease capital of the world. Next slide. So therefore, we will require dedicated trials or prospective observational studies of carefully monitored but high potassium salts in CKD stage 4 to 5, or in dialysis patients, in kidney transplant recipients, even maybe in heart failure patients, in diabetes patients, and elderly patients on RAS inhibitors. Next slide. Though the ESH guidelines, they do recommend, and the NICE guidelines, they do recommend the benefits of reducing blood pressure using high potassium salts or low sodium diets. But however, if you look at the trials around the world, then we have very few trials which have been done in kidney patients. So I think this is one area where the research will have to be carried out. Next slide. Modeling studies, they are very important. The modeling studies are using Indian CKD prevalence, drug use patterns, and lab data to estimate the benefit-risk trade-offs and to refine the contraindications. The contraindication language for national guidelines need to be undertaken. Some of the modeling, next slide. Few modeling studies have already been undertaken and few in our country are also there. The one in India is on nationwide salt substitution. And this study has shown that if we do nationwide salt substitution, this can prevent around 8 to 14% of annual cardiovascular deaths. Similar things can be done if we model them in CKD patients. Next slide. So cluster trials and qualitative studies, they can be conducted to compare the different delivery models. Now, this is going to be very important because we understand the importance of shifting from high sodium salts to low sodium salts, but how do we deliver them to the population? So I think that kind of studies need to be there. Shailesh mentioned that the national guidelines should incorporate the use of low sodium salts, but the guidelines are guidelines, as you know. But if we want them to come into action, then we need to show that how this can be done. I think for that also we'll require some implementation research studies. Next slide. Now, coming to the most important thing, the economics and equity. This is very important because I think most of the potassium we are importing from other countries. So as a result, the cost is going to be very high. When the cost comes high, then it means this is going to be available to higher economic status population as compared to the lower economic status population. And let alone thinking of public procurements. When we are thinking of public procurements, I think the research should estimate that what are the amounts which will be required for these procurements and from where do we get them? So how do we, and what are the policies which the government should make so that this salt becomes available for putting it into the public systems like the midday meals and others. But a very good suggestion, but this will have to be worked upon. For that also, the research recommendation, we have made a very important research recommendation. Next slide. So this is again the same thing which I have already said, that there is a low availability of low sodium salts in the country, and therefore we have to see that what policy changes will be required so that the availability is increased. It may be something to help the industry in production, or maybe some import taxations will have to be relaxed. So those kind of things have to be worked along with the government. Next slide. I think I am at the last slide. Thank you very much. Thank you very much.
Thank you, Dr. Sharma, and a big thank you to all the speakers for taking us through all the consensus statements that we had under the 4 domains, that we developed under the 4 domains. Now we come towards the next session in the agenda and the last one, where I would request Professor Jha to kindly moderate a panel discussion on translating the consensus statement on low sodium salt substitutes into clinical practice. So Professor Jha, I would request you to kindly moderate the session and also introduce the speakers. Over to you, sir.
I was speaking, but I'm muted. So thanks, Suparna, once again, and thank you to all the 4 speakers for really highlighting the consensus statements and the value of those statements. What do they mean? what are the challenges, how can we work with all the stakeholders in making sure that we have the consensus statements actually taken to where they need to go. So that's really the most important bit. And we'll try to unpack some of that during this panel discussion. And in this panel discussion, I'm really privileged to be joined by three eminent colleagues. And these three eminent colleagues represent different domains, but with them, they bring vast amounts of clinical experience of managing people with various kinds of non-communicable diseases where the use of low sodium salt substitutes is potentially impactful. So it's my pleasure to introduce the three panelists, and let me start by introducing the lady in the group. That is Dr. Meenakshi Sachdeva. She is a dietitian from Tamil Nadu Government Multi-Super Specialty Hospital in Chennai. She has a long experience in clinical and therapeutic nutrition. Currently, as I said, serving as a dietitian in this hospital, but she's also a faculty member in clinical nutrition at Madras Medical College, Chennai. So she brings academic rigor to her work and has her positions. She has held prominent leadership roles, including the chapter convener of the Network of Professionals in Food and Nutrition, Chennai, National Executive Committee member of the Indian Dietetic Association, and the treasurer of the Association of Diabetic Educators of India. She has received a number of prestigious awards, and I'm not going to list all of those awards because it's going to take a lot of time. So welcome and thank you for joining us, Dr. Sachdeva.
Thank you so much, sir.
The one after that is Dr. Professor Ambuj Roy. Professor Ambuj Roy is a professor of cardiology, and he's also the head of Skill E-Learning and Telemedicine facility at the All India Institute of Medical Sciences in New Delhi. Professor Roy is a fellow of the American College of Cardiology, National Academy of Medical Sciences, National Academy of Science, India, and the Royal College of Physicians. So multiple accolades. He is a clinician researcher with extensive experience as a clinician in managing cardiovascular disease patients in low resource settings, but also in contributing to the research ecosystem, which focuses on cardiovascular epidemiology, preventive cardiology, and translational research aimed at mitigating the rising burden of cardiovascular disease risk factors in low-income countries, which is really the way to do it. Because often as specialist physicians and super specialists, we get increasingly pulled in the area of technical therapeutics rather than prevention. So really admirable that Dr. Ambuj Roy is focusing so much on prevention. He has a number of ongoing studies on developing anti-inflammatory Indian diet, using vaccines in prevention of heart attack, and using digital health in reducing blood pressure and diabetes burden in India. And he, as academics typically do, he has a very, very strong publication record, and he features in Stanford University's list of the world's top 2% scientists, and he's done so every year for the last 5 years. So welcome, Professor Roy.
Thank you, Professor Jha and Suparna, for this opportunity. It's an honor to be on this panel. Yeah, thank you.
Thanks. And last but not the least, really, my pleasure to introduce a very dear friend and my fellow nephrologist, Professor Sandeep Mahajan, who, as I said, is a professor of nephrology at All India Institute of Medical Sciences in New Delhi. He is also a prominent clinician and a researcher, and has held a number of leadership roles. He's a counselor from South Asia region in the International Society of Nephrology, and a chair of the regional board of the International Society of Nephrology. He is an educational ambassador, providing education in kidney disease to different colleagues around the world. He's a fellow of the International Society of Peritoneal Dialysis, and currently the secretary of Peritoneal Dialysis Society of India. And he, again, brings a very nuanced understanding of how to use various therapeutic interventions in managing people with non-communicable diseases, including chronic kidney disease. So we'll start the discussion. And maybe we can stop sharing the screen, Suparna, so that we can see each other. I don't think that we have anything to do with the screen now. So if is Dr. Mahajan online? I don't see him.
Yes, he is.
He
Yes.
is.
Yeah, good evening, sir. Good evening.
Yeah, we
Yeah.
need to see your face, Sandeep.
Sir.
Thank you. So look, let's start by just a general question to all the panelists. We have heard you've participated in the development of the consensus meeting. Uh, uh, and you know, you are all ambassadors, and we have all the participants also in this webinar who are hopefully will eventually become ambassadors for the use of low sodium salt substitute. But it's really our very important responsibility to take this message to the entire community as well. So, in your opinion, what are the key messages from this consensus conference that clinicians and practitioners may take home and disseminate amongst their colleagues, etc.? So maybe I'll start with you, Dr. Sajdev, if you could share your opinion or view.
Sir, as you very rightly said, it's a therapeutic intervention. And thankfully, we have evidence to back this therapeutic intervention. Most importantly, it is practical, it is doable. And I heard Dr. Sharma just make a mention on one of the important barriers could be what she said was probably the cost. I would say that also is not a barrier. You will believe that I did make a mention of this previously also, that in Tamil Nadu, say 10 years ago, they had the Amma low sodium salt, which was available only for 10 rupees. So I'm sure cost is also not a barrier. It is very much implementable and doable. And if I'm to deep dive and tell that WHO very clearly tells us 5 grams of salt. So if I'm to extrapolate the cost which is available presently in the market of the low sodium salt substitutes, if I divide that cost with 200 number of days, the cost is only 25 paisa per day if I'm to use a low sodium salt substitute. Whereas if I'm going to use a regular salt, it's about 12 paisa. So you can imagine that I don't think cost is a constraint or a barrier. So with reference to our consensus, it's doable, practical, evidence-based, therapeutic, and there is enough data also to tell us whether it's hypertension, whether it's stroke or associated mortality. We don't have an issue. And most important part of it, it's not only salt restriction or reduction, it's also talking of substitution with potassium. So it's wonderful. I would say a great combination. And I've been a ardent follower, and I would say even I've been using this for more than 3 decades. It's not, I think we are talking about it and making noise about it off late, but I think the noise has started very long ago. So that's my take on this.
Thank you very much. Professor Roy, what is your view of what is it that one message that we should pick up and maybe spread, which would be most effective?
Yeah, over the last couple of months that we've been working on this document, I wondered why something which has such a strong evidence, fairly strong evidence, I would say, and is a class 1 recommendation, the most this year's ACC/AHA blood pressure guidelines, and 2A in the ESC guidelines, level of evidence A. I was wondering why it is not translated as much as it should. And hypertension is such a big problem. We have a conservative estimate is 33% of the population has hypertension. If you look at the newer definitions, the American definition of 130/80, almost half of our adult populations becomes hypertensive. And hypertension constitutes about 40 to 50%, depending on how you estimate risk to coronary artery disease and stroke. So we need a all hands on the deck approach. And I was wondering why we've not been able to translate this relatively easy intervention into practice. And I think that's where our research should probably focus on. Because I think it's easy to write a medicine, it's easy to tell something about the diet, but this probably falls in between where you need to prescribe, or I don't know how do you do that. You prescribe low salt substitute, like you write a prescription. Somehow clinicians, I have never seen that kind of prescription. So I think we somehow need to inculcate that in our teachings, in our dissemination through various cardiology societies, nephrology societies, and physician societies to make this intervention more noisier, if I in the absence of any other word, but make its presence felt. Somehow, I think we've not made there is evidence, but we've not made enough. It's not made enough impact as it should, and I think I think this is a great way to do it. But I think we'll have to latch on to more societies, or as I said, governmental programs to make it a way make it more use to make its use more widespread.
Yeah, thank you very much. I think you make a number of important points there in your remarks. The mystery of why something which has such a strong evidence is yet to be picked up. And I guess one of the reasons is that there are a number of, I would say, interested parties that latch on to, the small bit that talks about its potential harm, such as those in kidney disease, and blow it up out of proportion. So I think we need to all, as this community, go and sit on a dharna outside ICMR so that it can fund such a study, which will be able to show whether there is real harm or not. That's something we have been trying to do. So I think the 100 people who are on the call should go and sit on dharna outside the ICMR. But I think, jokes apart, the point that you made about the dissemination is important, and my mind goes to an even earlier time in life. Nowadays, in our schools, we have our children in very early classes, primary school education, learning about the intricacies of genetics. Why can't we start this there? So as we teach them genetics, as we teach them about basics of physics and climate change and all of that, this should be a matter of education as well. Health education should feature more prominently, including such a very simple intervention. So that very, very important points. So thank you for raising them. Dr. Mahajan, in addition to addressing this, I think we all understand, you and me and many others, that kidney disease is the big bugbear, right? In talking about the use of low sodium potassium containing salt substitute. So your views are general, but also specifically, if you could address what we can do as a community.
So obviously the downside for widespread or general recommendation, population recommendation for low sodium salt is that there is a small percentage of patients who can be at harm. And chronic kidney disease patients, by virtue of their disease, and also by virtue of few drugs which they are on, which are nephroprotective, but they also increase the serum potassium, they are the ones who are most susceptible to this hyperkalemic chances of using low sodium salt. And I believe this is one problem which either is overhyped, or the magnitude of patients we are talking about maybe are too small, and they can be differentiated. It's not that they can't be differentiated. We can have a simple checklist that if you are on these set of drugs, which could be RAS inhibitors, which could be potassium sparing diuretics, or if you have chronic kidney disease, at least if you know, you should not be using these drugs. We have now such a huge packaging propaganda. You would see every say, even a cigarette pack would have such a florid warnings. So similarly, we can actually make these packs in such a way which can tell that if you have any of these three, please don't use this salt, or consult your doctor or get a blood test before using this salt. So that would free approximately 90% of the population which can use that. We are just looking at a small proportion, not even 10%. I would be believing that this would be patients with advanced stages of kidney disease, and on that particular group of drugs, which would be only 3 to 5%. So, as I said, the potential harm is real, but the magnitude of that potential harm probably is too little to avoid using this as a more widespread therapy. I believe it's a lot to do with therapeutic inertia as well as the inertia from the general population. So we as physicians are not energetic enough to propagate this kind of therapy, number one. And number two, because of various misconceptions regarding the taste, regarding the cost, people are not that easily picking up these salts from the shelf. So I believe if we just reassure the public and we reassure or we form a simple 3-point guidelines for which patients should be cautious in taking this salt, this can do a great justice to this therapy for a more widespread usage.
Thank you, Dr. Mahajan. Right, so we have questions coming into the Q&A panel. Please I encourage you to freely mention whatever doubts you have in mind, because eventually, as I said, we do hope that you will become the ambassadors for this message. So one of the questions that came in, Dr. Sachdeva, is how do you prescribe this salt substitute in your practice? And there is even a question, do you provide it in your hospital? Can you share some tips about how other hospitals can implement this practice?
Sir, with reference to where I work, it's a government institute. So it's a government order. It cannot be just provided, offhand. That is one thing. But definitely in my private practice, not only in my private practice, in my, people whom we know. Like recently, I knew of somebody close to me who was, diagnosed with hypertension and was prescribed a medication for hypertension, but unfortunately not ready to even start the medication. I wouldn't say first thing is to not start the medication. He needs to start the medication. But the moment I told him that you have not started medication is not right. But immediately also tell him that you please, screen for your renal profile. Come back to us with your potassium. If your potassium is doing good, you immediately start with low sodium salt substitute. That's the first step you take. Obviously we are in the thought process that there are potassium rich foods also which can be prescribed and which are prescribed in order to help the patient in all forms, because they don't come only with potassium. They come with fiber, they come with phytonutrients and so many other health benefits, but this is one add-on therapy. So whether my patient is obese, my patient is at risk of osteoporosis, especially the postmenopausal women. The third category is who have a history of stroke in their family, who've had history of CAD, CVD. We can blindfoldedly, I usually prescribe low sodium salt as part of my dietary prescription, as part of my prescription. My only worry is when my patients are there who are not sure that they will come back to me. CKD stage 1 also very boldly I prescribe. CKD 2, I'm little scared. The reason that if they do not come back follow up, I need to reinforce to them that if your polypharmacy is increasing, the number of drugs is increasing, please talk to your doctor whether you can continue the low sodium salt. That is that much of understanding the patient should have. Otherwise, it's free to use, whether it's obesity, whether it's hypertensive, whether it's metabolic syndrome, whether it's postmenopausal women or family history of any of these chronic conditions. It's a very simple and effective way. And as I mentioned to you previously, it was available in the PDS in Tamil Nadu. So I have no apprehensions when it comes to LSS. Another important thing, people are talking of taste. Believe me, you move 15% substitution, there is no difference in taste. Only patients will tell you, ma'am, thoda namak kam dalta hai. You need to add a little more to get the taste. That is all. Otherwise, in fact, when they start using it, the first 2 days, it's a little difficult for them to adjust the salt ka taste in the food. Otherwise, within a week's time, they get used to it. Believe me, there is no metallic taste. Metallic taste comes 50%, 75% when it is replaced with potassium, not with 15% at all. That I can give you 200% offhand experience as well as patient experience. Another important thing I forgot to make a mention, patients with CA stomach. We have a lot of them coming to us with recurrence or with family history of CA stomach. We do make a mention that if your sodium intake is on the higher side, you're at high risk of CA stomach. So if they've had a family history of CA stomach or CA per se, we tell them to move to low sodium salt substitutes.
All right. Thank you very much, Dr. Sajdev. So I think there are two situations in life. One is a clinic situation where you have a patient in front of you, and in those individuals, we as all as physicians have the luxury to order as many tests and do risk stratification and decide who can take it, who can't take it, or shouldn't take it. And the other is population level interventions. As someone who designs public health program and implements public health program, we should all be comfortable with the fact that no public health program comes with 100% benefit in everyone in whom it is implemented. So there is some potential downside, but as public health policy makers, implementers, I'm not in that position, but whoever does it will need to take the overall risk benefit and approach. If the risk is vastly inferior to the potential benefit, then that public health intervention is likely to be something that will be recommended, as the WHO has done, for example. So that's just a general point. Dr. Roy, a question has come in the chat, and I'm pretty sure you've seen it, is that given that doctors are already very busy and spending a lot of time with their patients, how can they incorporate this conversation also into routine counseling without increasing consultation time or complexity?
Yeah, so I think all of us do advise a non-pharmacological therapy. However, briefly we may do it in a busy clinic, right? We all of them talk about physical activity. We talk about weight loss if they're obese. We talk about increasing fruits and vegetables. So kind of a DASH diet, right, that we prescribe. And if you're not doing that, then obviously you're not providing, I would say, appropriate care. So we all of us do that. I'm sure we do it pretty briefly, but we definitely do that. So it's just about adding this to that layer of non-pharmacological intervention. Well, if you look at, I was just wondering, I mean, this is more of a discussion and my own thought process is that if you look at the data in hypertensives, it's been shown to reduce blood pressure, LSS, been shown to reduce blood pressure by about 7 millimeters mercury, and in non-hypertensives 5 millimeters, which is actually equivalent to what average pill would do. That's the standard nowadays. We start treatments with half dose of most medications, and that's exactly what it does. So, I mean, I really think it is an equivalent to a pill. And if you look at most of the guidelines, and when they talk about starting therapies, they never talk about LSSS in their algorithms or the guideline flowcharts that they are there. And I think we have to be bold enough and make sure that this features as prominently as any pharmacological intervention does, because it is almost equivalent to what a pill does. So maybe those kind of advocacy for that kind of change may be important. I mean, after all, when we ask people to take RAS inhibitors, we always ask them to check for the potassiums, right? So similarly, it could be done for this. And I think we need to mainstream LSSS in our algorithms for hypertension management, because it's pretty potent, equivalent to most of the pills that we take. And we need to mainstream them, and advocacy forums will help getting this incorporated in various guidelines that come out with hypertension management.
Thanks.
In fact, the WHO fact sheet very clearly recommends to replace regular salt with low sodium salt substitutes for the population, except for those few.
Yeah, thank you. So, Dr. Mahajan, we are discussing how to increase the uptake, and we again keep coming back to the point of there being still skeptics and perhaps some genuine uncertainty in certain situations. So what do you think is the evidence that we need to generate which can reduce that uncertainty, or at least resolve it in one direction or the other, right? So, for example, you did talk about people with chronic kidney disease, and that people with a certain stage, this is something that Dr. Meenakshi Sachdeva also mentioned, that kidney disease, not all kidney disease is the same, right? I mean, there are degrees of kidney chronic kidney disease or kidney failure. So I don't think that it is fair to deprive the people with early stage kidney disease of the potential benefits. So what kind of evidence do we need to generate to resolve this issue, if any?
Dr. Jha, if we look at the current level of evidence, I think so the evidence is quite robust in favor of using low salt supplements, even in patients with chronic kidney disease. So, because potassium itself is nephroprotective and low potassium can actually be nephrotoxic. So, we have enough evidence to say that potassium is actually nephroprotective, and replacing sodium with potassium in salt is actually going to help you even if you are a kidney patient. There is a small proportion. So we again go back onto those small proportions. So if we go just by percentages, what we have evidence from India, we all would agree that chronic kidney disease would be around 12% of common population in India. Of those 12%, a good big majority would be in early stages of chronic kidney disease, where potassium is not at all a challenge. This story of hyperkalemia and dietary restriction for potassium would fall into patients with advanced stages of chronic kidney disease beyond a CKD stage 4 and CKD stage 5, and in some subset of early chronic kidney disease patients who would be on a particular group of drugs which help the patients in slowing the progression of kidney disease, but also increase serum potassium levels. So if we go just by percentages, that percentage in general population, as I said previously, won't be more than 3 to 5%. So you can't deny such a game changer from a widespread public use only for 3 to 5% of the population. We only need to be having some safeguards or some easy screening tools to get to know who those 3 to 5% are. Unfortunately, in India, we don't have a universal coverage of all the tests, of so many investigations which are required. We don't have that kind of data in our general population. So, as I hinted initially, it would be best left one to the discretion of the patient and the caregiver by just giving them broad criteria as to which patients are at a risk and who should be tested in case required. And if we are still giving these patients low sodium salt, which I believe we should be giving them, we should be checking them a bit more frequently. And that would be, say, for early stages of chronic kidney disease every 3 to 6 months, and for patients with more advanced stages every monthly. And that would also depend upon the drugs. So as far as the level of evidence is concerned, I would believe, as Dr. Ambu said, we have good, robust evidence that low sodium salt supplements are going to be beneficial to a vast majority of patients, even with chronic kidney disease, not only by controlling blood pressures, but also slowing the progression of chronic kidney disease.
Yeah, thank you. But just pushing that point a little bit more, you are absolutely. Of course, all of us 100% agree with you, right? And we wish there was no need to say anything more. But there are still some skeptics around. So, do you think that, as you said correctly, that a vast majority of people out there in the community who have kidney disease have early stages of chronic kidney disease, who may be undetected? We do think that people with more advanced of chronic stages of chronic kidney disease are likely already identified or diagnosed. So do you think there is still value in doing a randomized clinical trial in people with early stages of CKD, let's say up to stage 3, to prove beyond any doubt that the risk of hyperkalemia is not substantially higher? Do you think there is value in doing something like that to convince the skeptical community?
Well, I think so. You said that we would have to grow the ICMR to really have a fund for a study like this. This is going to be an extensive exercise. Would require a long-term follow-up, and with all
It
those
should require,
compliance issues.
no, I think what we need to do is just do a 3-month follow-up, because if hyperkalemia has to appear, it will appear, right? And if we can do a 3-month follow-up, we will know whether or not they're going to develop hyperkalemia by use of potassium-containing salt. So, or in fact, if we do sample size calculation, it won't require a huge number of participants as well. So it is an eminently doable study, and if done properly, within about a year or so, we can get definitive results.
Yeah, if we just look at the safety profile, then obviously it's doable.
Yeah,
But
exactly. That's what we have to look at. Yeah.
if we have to look for the benefit, then obviously you would be requiring
No, we are
huge
not looking at
push
renal
calculation.
benefits. We are not looking at.
Yeah.
So I think the main thing
The
is to
whole
convince.
issue is to reassure. Yeah.
Yeah,
Is to
reassure people about that there is the risk of hyperkalemia is not not as severe as.
Yeah, it's not as big as it is made out to be. Yeah, I would
Correct.
agree completely.
Yeah, completely. So again, just going back to you, Dr. Sachdev, what are now you have a question also in the chat about the use of pink salt and Himalayan salt and other types of misconceptions that you might have heard. So if you can briefly simply describe what exactly does that mean, and what should the attendees go back with regard to all these myths and misconceptions.
Sir, if I can read the chat, or it's just that you want me to make a mention on all the various salts which are available in the market?
All the types of salt that people use, thinking that
okay.
they're using some sort of healthy thing.
Yeah, okay.
Something.
So basically, the various salts which are available in the market, from the sea salt, table salt to the pink salt, so many salts are available in the market. In fact, there is also only potassium salt. So only potassium salt is, believe me, very, very metallic, and I don't think we need to go to that level to, wherein we are able to achieve what we wanted with reference to blood pressure and associated problems. I think the 15 to 20, 30% is more than enough. We do not need to replace it with the 100% potassium salt. The second important thing is the various salts which are available in the market. If you see the sodium reduction with reference to table salt and sea salt is better than the table salt. That is the second aspect. Third aspect is all the pink salt and senda namak, ye namak, all of them are having some amount of potassium, but it's almost the same. The sodium content, potassium content is almost the same, very small difference of few milligrams. So if I am to say a therapeutic intervention, I have to only look at a low sodium salt substitute. I cannot look at the various different varieties of salts which are available in the market in order to achieve the therapeutic benefit of a low sodium salt substitute. In fact, it will be very interesting to note that not only in the urban population, as early as 2011, when they had done a study in Andhra Pradesh, they found the salt consumption was 42.3 grams in the rural population. And in fact, you won't believe, recently I had a patient who came to me for hyperuricemia, and he has worked a small stint in Andhra, wherein they consume a lot of gongura and other, accompaniments to add on to their diet. He was telling me, madam, you tell me anything, I will follow, except that telling me to reduce the consumption of XYZ, like gongura and papad and all those things in his day-to-day diet, because they're so much accustomed to excessive sodium intake in their diet. So Andhra is one area which really requires a target if we want to really, see a therapeutic benefit. That is one area which needs to be understood. Apart from nephrology, already knows that, Uddanam village has a lot of CKD of unknown origin. Other than that area, I think Andhra is one area which you really need to target if you want to look at the therapeutic effect of low sodium salt substitutes. So that is one.
I think in summary, the question that was asked is that, look, I think if you take weight by weight, all of these other types of salt, with the exception of low sodium salt substitute, they contain exactly the same amount of sodium weight by weight. So pink salt, rock salt, all of that is no different than table salt. The other difference between those is that they're not processed. The table salt is processed, so it doesn't contain anything else. Whereas those unprocessed types of salt, they contain trace amounts of some other chemicals, like there could be a bit of potassium, a bit of magnesium, and so on. But those are all trace amounts. They are not, they have no health benefits at all. So do not go with the assumption that any of these other type of salts confer any type of health benefit. Okay, so that's
In
really very
fact, they
important.
range from as low as 182 milligrams to as high as 285 milligrams of potassium. That's it.
Yeah, so there is no value in health value in any of those,
That's
and
true.
they're also a little more expensive. If you like them for some other reason, just you can consume them with realization that they don't have any iodine, so you're losing that benefit, and that there is no difference in the amount of sodium between the two. So you can still take it, but you don't get any health benefit. So absolutely important. So going to back to you, Professor Roy, you made the point yourself about the guidelines. What can we do as a community to convince our Indian professional societies to maybe come up with a set of joint guidelines, advocacy paper, etc., on this topic?
Yeah, I think we need to align with these societies. I think the problem with the salt substitutes are there are no major, if I can say, industry pushing them. As it happens for many of the, I mean, that's the fact of life, as it happens for pharmacological interventions. We don't see that. So it will have to be through academic institutions and organizations like yours and ours, which we need to do, and we need to probably write to various societies where it could be, Association of Physicians of India or Cardiology Society and nephrology societies, to probably hold sessions in the conferences which are well attended, to make this, as I said, make more noise about it, so that it is. I also work in the field of, in fact, flu shots, and most of us know that it is a class 1 indication. But the uptake, when we saw in a heart failure trial, in a randomized trial done in tertiary care, it was under 1%. So some of these interventions are not converting into therapeutic use as much as they should be. In fact, they are very, very underused. So I think I see somebody writing on the chat. We need to engage with societies. We need to engage with policymakers. We need to engage with if it is the political class, who are the decision makers, to take this forward. And it requires a lot of push, I think, because as we've been saying right through this panel discussion, there is a lot of evidence, but that evidence to action is missing. And we need to really do all these things to convert the evidence to action.
No, absolutely. There is a big, as they say, between the cup and the lip, gap between the cup and the lip, which is what we are facing literally here. That it is there in the markets, and but we are not able to push it to where it needs to go. Dr. Mahajan, you hold very important positions now in many professional societies. How do you think we can push some of these societies to propagate the message?
Well, I think so. Dr. Ambuj has pointed out repeatedly that though the guidelines are there, we have the proven benefits. It's a strong recommendation, supported enough by literature, but still it has not come up. I think so. The main problem is, as I said, the inertia in the whole medical community to a therapy which is non-pharmacological. So though we believe that it's a pharmacological therapy, but it's not in the form of a pill. It's in the form of a salt substitute. Uh, we have been talking repeatedly about, as Amber said, creating more noise, creating a bit more hype. You would remember seeing a television ad selling a salt 100 rupees a kg, just by saying, just by keeping XYZ and saying, yeah, it's good for my health. So I believe we as societies are we have enough support. If we have enough support, we should appeal to a larger audience, and that is the population who has to take it up. Once we do that, because coming from professionally from doctors, it's I think so it's a huge inertia because it's not a pill. It has to be taken from a supermarket. So I believe the end user should be the one who is empowered enough to buy it straight away from the shelf. Why you even require a doctor's prescription for that? If it's an intervention as easy as that. So I believe we should now have some propaganda, some noise besides the scientific committee, also in the lay public, in the lay community, so that in print media, so that people now appreciate that this is one intervention which is so simple, so useful, that it should be taken up universally unless you have few issues regarding your health.
Very well said. I think we do need to start a movement, as we all are saying. We need a critical mass. There are a number of people here in on this Zoom call. I hope that they all go back and disseminate this message. You know, all of that needs to happen. I think, but we do still need to ensure that work with governments also to so that they also have a skin in the game. Right now, the government does not seem to have any skin in the game. And so if the government can at least make even a couple of pronouncements, including maybe an important thing they could do, although the data was presented by the team that the eventual rupee cost or paisa cost is marginal or even trivial, it still matters for people, and people do want to that even if it's a small difference, it's visible. So if the government can announce a subsidy on low sodium salt substitute, that will have at least an effect, not really in the sense of providing financial benefits, but it will have at least from the point of view of publicity, that's something. The other thing we could do is maybe try to find someone like Amitabh Bachchan, even if he's aging, he still holds a lot of pull. Someone like Amitabh Bachchan to come and speak about it. Dr. Roy?
Yeah, I mean, I was just thinking, I mean, let me be candid. I have not written a prescription. I don't remember one in the last 4 months. For example, one last month to have written that on my hypertensive patient prescription. But if I have to put you on a spot and you have to write it on your prescription, how do you write that? I mean, you write the brand name, you write, what do you write? So sometimes having medical, it being a kind of available in, as Sandeep said, available in a drugstore is better than being in the supermarket, because you're not used to writing prescriptions of supermarket, right? You don't go and buy, the best olive oil, X, Y, Z, olive oil. So similarly, so how do you prescribe, if I have to put you on a spot, for practical uses for people who are listening, how do you write that prescription of this salt substitute?
Yeah, indeed. That's right. I think there is no prescription.
One situation.
We have to make it into a product, a medical product, which is the challenge with the way medicine has become, honestly, right? In many parts of the world, including in our country. And again, look, if we take the example of the UK NHS rewards any practice that can prevent people from coming to the hospital, right? Reduction. Now, one of the goals is reduction in hospitalization. And those are the kind of things that we also need to consider, because these are the kind of things that will happen. there is, I think Suparna has said that it is important to engage with dietitians to write that prescription. So, all right. So maybe how about your opinion on this, Dr. Sachdeva? What do you think will happen?
We've been
Will
doing
this?
it, sir. We've been doing it, but the fact, as mentioned, it needs to come from the horse's mouth. So when the doctor does it, it's more impactful, but we've been doing it. So it's
How do you
not new
prescribe
for
that?
us.
How
But
do you
we do tell
prescribe?
them to take the potassium. In fact, I told you, you should push it into the PDS. It should move into the PDS. It'll make a world of difference. The noise will be maximum when it comes to the PDS. And second is, that's part of every hypertension prescription. It should be part of it, no matter what, whether hypertension, obesity, cardiac patient, it should be part of it. Obviously, the ifs are there. That is only a very small percentage. Every MNT protocol should have it. And I would say it's a pinch for a change. In
So, ma'am,
fact,
how
ICMR
do you
NIE has it. That is a pinch for a change. It already has it. In fact, the dietary, there are 17 dietary recommendations released by ICMR in 2024, which do talk about, control of blood pressure and all of it. When I think we can put a small word of low sodium salt substitutes. So that will also make most noise. In fact, we have a lot of eat right movement wherein they say, aaj se thoda sa kuch kam. So such sort of taglines have to go in where we need to talk of potassium based salts. As sir very clearly said, no, Amitabh Bachchan, it's like ek boond, do boond zindagi ke. So these things are very important. They take a, I would say they go a long way for years together.
So, ma'am, practically, what's your prescription when you write this? Do you write the brand?
No,
Do you
I
write...
tell them potassium based salt, but since I'm working in the government myself, I cannot write the brand name, so I tell them orally.
Okay.
There are 2-3 brands which are available, which we've been using for several years. But I very rarely use the 30% wala. I use the 15% wala. Safer side.
All right. That's a fair point. I think you do it in your practice, which is great. But if my experience is anything to go by, most dietitians don't do it. Just like most physicians don't do it, as Dr. Roy said. Look, so this is not not a screed against dietitians from me. I'm saying
No,
this is
that's okay.
universal,
I think
right?
it's just your way of working. Nobody has taught us to do it. It's on our own. We have started doing it, right? So I think each one's perspective of handling a patient is different. Like how
Yeah.
in my CKD prescription, I would definitely write no asulfame potassium. I would tell them no low sodium salt substitutes. So I give them a list of no's. So in that, I would have that separately. So similarly for my hypertensive, I do have replaced the regular salt with low sodium salt substitutes. So it has to go like that as a print. When it goes as a print, it is part of life. It's a behavioral strategy.
Yeah. Okay. I think there is a separate conversation to be had about how we give dietary advice to our patients. And I have some strong views about it, but then that's a separate conversation, perhaps at a different time. But look, we just keep coming back. Someone raised the issue of behavior change communication. And it was Dr. Sailesh Mohan, I think, who mentioned this, or I'm not sure who was it. I think it was Dr. Mohan who mentioned it. But does any of us have any experience with behavior change communication with regard to changing salt intake?
We do tell our patients not to have ultra processed foods because they are a bumper source of sodium, saturated fat, and sugar. So that's a form of behavioral change.
Yeah, but behavior change communication is different. There is a different science around it. Simply telling patients is not necessarily behavior change communication.
Reinforcement only works. Telling
Yeah.
once would never work.
So how do we do it? Is something for us to maybe think more about and perhaps see if there is any specific type of behavior change communication that works in such a setting, and we could see whether it is possible to implement this type of thing.
Probably this could work through IEC material or a QR code with IEC material.
Yeah, possible. All right. I think we have covered any other issues that any of the panelists or anyone would like to bring up before we draw the meeting to a close. We have had quite a substantial discussion.
I think one last word from me would be numero literacy. So if the patient is aware of his potassium status, I think good to go.
Yeah, that's important. Everyone should know about what they have and how they can actively participate in their own management in a way that is beneficial. That's an important point. So look, if there is nothing else, then all that remains for me is to thank the panelists, Professor Roy, Professor Mahajan, and Dr. Sachadev, for your very important interventions and suggestions and thoughts and sharing of experiences. Most importantly, also recognizing that there are uncertainties, right? That we don't live in an environment where everything is certain. One thing about which there is some degree of certainty and has a grade 1 recommendation, we are not able to implement well. So that's also something for us to continue to think about. So thanks everyone, and wonderful thanks also to all the participants who have hung on for close to 2 hours. It's not easy to do on a Zoom meeting. And also for all your comments in the Q&A and in the chat boxes, which does mean that there is a fair degree of interest on this topic. We will keep coming back to you. We have your information. And if you have anything else, then please do reach out to us. And we have work ahead of us as we discussed, and this is not the last one that we are going to do. So thank you, and I'll hand back to Suparna.
Thank you, Professor Jha, and thank you all the panelists for this insightful discussion. And we do have some questions in the question answer panel. Is there any question that is not answered? Nana, if you could quickly let us know.
I think we have covered everything. We have covered everything. I was monitoring the panel, and I think we have covered everything.
Great, great. So thank you, everyone. I just need to thank a few people who have helped TGI to organize this particular webinar. So yeah, the tireless effort of the comms team of TGI and RTSL, especially Abhishek, Kunika, Jenny, and other colleagues at George and at RTSL. Of course, the nutrition team at George Institute and the RTSL team with Professor Imran, Manika, and Laura and others who have really contributed to this consensus statement and the white paper that we have developed during the course of 6 months of our intense activity that has happened. So I would just like to thank everybody, our impact and engagement team at George and the IT team at George. I thank them all, and it was really a pleasure to have you all, and we will keep you posted. This is an exciting, interesting topic. Well, this is there for the past 15 years, but at least with the effort during the last 6 months, we have been able to generate this consensus statement, the policy brief, which we are going to present to the government, and we will take this forward. Thank you so much, everyone. Thanks for joining.